We're fortunate to host this HITH Grand Round webinar focusing on eye infusions at home. We're joined by two incredible speakers, Dr. Colleen May and Julie Adams from Western Australia. Dr. May is a haematologist with extensive experience managing busy eye infusion clinic, who will provide clinical overview and share her insight on best practices, including the management of iron stores and addressing iron deficiency. While Julie, the co-director and founder of Chemo at Home, will follow with real-world insight on delivering a high volume of eye infusions in the home setting, highlighting the practicalities and benefit of this innovative approach. I encourage you all to actively participate in discussions later and share your thoughts or questions in the chat, which I will read out at the end of the two presentations. I'd also like to take a moment to thank everyone who made this event possible, our speakers, you, our attendees, and the society members whose financial support ensures events like this continue. If you're not yet a society member, now is a great time to join. Just scan the QR code, the corner of the screen, to become part of this growing community. Before we begin, I would like to remind everyone that our guest views are their own, and they do not represent the official position of HITH Society Australasia. Likewise, my opinion I share today are entirely my own. Now, let's dive into this exciting session, starting with presentation from Dr. May. Over to you.
Thank you very much, everyone. I'm going to see this one here. I've never shared a screen before. Can someone see that?
Not yet, so it should just be on the right corner, the shared screen, and to pick the window or screen that you're after.
Yeah, I did. Wonder if I need to move it to this screen. Is that working?
Not yet.
Okay.
You can always, if you like, email me the presentation. I can share it.
Can you see it now?
Not yet.
Okay. Okay. I am not sure why this is not sharing.
That's okay.
Could you see anything that I was sharing?
No, we were not able to see anything. Julie, were you able?
No. Colleen, it will have a red box around the screen when it's shared.
Okay. Yeah, I'm not entirely sure.
That's okay. Would you like to email it to my email? Now I will then share it.
Yeah, okay, I'll do that. I mean, it says it's sharing, but I can't see how to share it if that doesn't work.
Technology, unfortunately, we all struggle at some point in our life with it. And it is, of course, the first presentation of the year after the new year.
So I have sent that to you. I don't know how long it will take to get there, though.
That's all right. What we might do in the meantime, we might get Julie. Do you want to present your presentation?
Sure, absolutely.
And while we say that, I just got the presentation. Perfect. All right, so I can happily share this one for Colleen, and all you'll need to do is just tell me when to change over the slide.
Do you want to go first with Colleen then, since you've got the presentation now?
Yep,
Yes,
we'll
please.
do Colleen's one.
Okay, I'll stop sharing my screen. Great. Thank you.
Okay.
Okay. So yes, this is a haematologist's views on iron infusions. I tried to cover the talking points supplied in the email you sent, and I will try and talk around those subjects. Next slide, please. So I work in the WA Specialist Clinic at Osborne Park. I also do occasional iron infusions down in Rockingham at Icon. But the WA Specialist Clinic runs a busy iron infusion clinic that does about 80, so between 70 and 100 iron infusions a week. It's in a clinic setting, so a little bit different to the home setting. And I do 2 lists, averaging around about 25 patients a week myself. Most of the iron we use is Ferinject. We do use Monifer as well, but most of my experience is with Ferinject. Next slide. How important is iron? I think a lot of us do know that iron is important, but not necessarily how wide-ranging its effects are, because practically every organism on the planet is actually reliant on the use of iron and the way that it reacts with other molecules to provide energy. There is evidence from as far back as a few thousand years ago that early human civilizations actually recognized iron as important in health, and it was used in medicine as well. That's how stark the effects of iron can be. Next slide. I think everybody knows the consequences of iron deficiency include anemia, and up until relatively recently, all of these other symptoms, fatigue, tachycardia, the pica, so especially craving ice, reduced productivity at work, most people, doctors especially, felt that they only happened if a person was anemic as well as iron deficient. Which is true, but if you go to the next slide, there is now a good recognition of a syndrome called symptomatic non-anemic iron deficiency. So it's now been confirmed that the presence of iron deficiency, as measured by ferritin mostly, can cause symptoms very similar to those associated with anemia before a person has actually achieved technical anemia. Anecdotally, over the last 8 years of working in the clinic, it is obvious that most people tolerate ferritins down to about 30 micrograms per litre. We have a cohort of people who are regular attenders who very definitely have onset of symptoms when their ferritin is at or around 50 micrograms. There are also cases where I have one person, she's got an iron metabolic disorder, and she gets symptoms so bad, including hair fall, when her ferritin's below 300. So that's very much an outlier, and that's a genetic variant. We also have some people who come in a recurrent fashion anemic because they have no awareness of that. They do not get symptoms. I compare them to a diabetic who does not have symptoms of the hypoglycemia, and those are definitely people who require much more monitoring than the average person. Next slide. In our clinic, the most frequent users of iron infusions, and this is borne out by, I think, everyone who does iron infusions, people who menstruate. That's 80% of our clientele. And because of that, medically, if you're looking at iron infusions, you need to know how to take a menstrual history. It's very important and very difficult. Pregnant people would be our next biggest cohort. Interestingly, a lot of women don't access them in their first pregnancy, but tend to put their foot down and get one in their second onwards. And partly that's because a lot of women go into their second pregnancy with significantly lower iron stores than they do their first one. The rest of ours would be people with chronic diseases, especially heart failure and chronic kidney disease, people with restricted diets due to mood disorders, cultural practices, finances are a big one. We are not seeing a lot of those people because those people can't afford the iron infusion as well. Some people develop food aversions, and there's also people who choose not to eat certain foods. There's also a subset of people who do not absorb iron well. One that's becoming a lot more common is people with sleeve gastrectomies. So iron is one of the many things they do not absorb adequately and needs monitoring. Undiagnosed or inadequately managed celiac disease is a big issue. And there's also familial syndromes of people who do not absorb iron, and they do not hold on to iron. There tends to be a family history, and it actually starts affecting males in the family after a few generations. Next slide. The adequate menstrual loss management is difficult. There has been a lot of research since the 1970s trying to accurately estimate how much a person is bleeding every month. The scientific definition of excessive blood loss is 80 mils a month, but in some people, 80 mils is easy for them to manage. They're good at absorbing iron. They've got a good diet. They don't even notice. Other people don't necessarily have blood loss that severe, but due to diet, lifestyle, or body size, their bleeding can lead them to become iron deficient. So ways that have been measured, things have been measured in the past. They've weighed pads, they've weighed tampons, they've tried to use cups and things like that. All of them have very significant inaccuracies due to undocumented losses at changeover. And I've been finding that modern technologies have been making asking a question, menstrual history, really difficult. The reusable underwear probably loses its efficacy over time. And I had one lady once. So we always ask a menstrual history, and one of the questions in our questionnaire is, are you changing what you're using every 2 hours or more? And I had one lady who answered no, because she was using maternity pads. She was going through 2 or 3 maternity pads in 24 hours, 1 to 2 days a cycle. So the modern technology can really hide the impact on a person's life that their menstrual losses are happening, because until she started using those pads, she couldn't leave the house. But the access to that type of pad and the knowledge that they existed freed her up a lot, but she was still becoming very iron deficient. So asking people what they're using, how much they're using. I had one lady, she ticked the changing every 2 hours box, but she was using the smallest pad available, and she was changing it as soon as it got dirty. She did not have heavy periods. Okay. The question, what are your periods like? Are your periods heavy? Is an unhelpful question for 2 reasons. A person's period is normal for them. It doesn't mean it's not heavy. It doesn't mean it's not light, but it is normal for them. And it's also often going to be almost the same as her siblings or aunts or mother. So if the only person she's ever talked to about her periods are her family, she's going to think that it's normal, because they're often all in the same boat. So asking what they're using, how much they're using, how full a product is before they change it, can really help you get an idea of how much a person is losing, because the best thing is to try and avoid needing recurrent iron infusion if we can. So menstrual management options would often come after that conversation. Next slide. So our next group of people using iron is pregnant women. Now, this is a slide from an Indian directed talk, but that graph is out there a lot. So you can see, and this is a graph of the daily estimated requirement of iron absorption. Okay, some people do not absorb, some people absorb very well. A lot of women absorb iron much better during pregnancy than they do when they're not pregnant. So some people do very well during pregnancy, they're fine. I've got women who do not need iron infusion when they're pregnant, but they need iron infusions when they're menstruating, which gives you an idea of just how bad their menstrual losses are. So yes, we see a lot of people in second and third trimester of pregnancy, and it's now well recognized that a person with a with a borderline or low iron can receive an iron infusion safely as preconception planning, and we do see people like that as well. Next, iron in chronic disease is probably going to end up being a significant portion of iron infusions going forward, I imagine, because it's becoming very well recognized that iron deficiency is going unnoticed in people with certain conditions because of the way inflammation interacts with ferritin and iron metabolism. So the most researched conditions out there are chronic kidney disease, heart failure, and inflammatory bowel disease, but we are starting to see the psychiatrists sending in patients with difficult to control mood disorders as well to get their ferritin above 100. The guidelines are very, very variable, but most of the specialists that we've had refer us patients for iron are asking for a ferritin above 100 and a transferrin saturation above 20%. Next slide. This is the current guidelines on heart failure patients, and explaining why the guideline is to keep the ferritin above 100 and the transferrin saturation above 20%. What I find very interesting are the top two left. Go to the next slide. There's a bigger version of it. The top two left ones, so ferritin below 30 or ferritin 30 to 99, but with a transferrin saturation above 20%, their mortality rate is equivalent, if not slightly better, than the people in the ferritin 100 to 300 with transferrin saturation above 20%. So those people don't need iron infusions necessarily. The ferritin less than 30, we would still infuse if requested, but the ferritin 30 to 99 with a transferrin saturation of above 20% may or may not need an iron infusion. Transferrin saturation below 20%, we give iron infusions, but note that ferritin above 300 is detrimental. So we need to be aiming for a ferritin between 100 and 300 micrograms per litre. I know it says nanograms. Oh no, that's per milliliter. But that is there's a cohort of patients I think we're going to see a lot more of, and we need to know about that upper limit as well as the lower limit. So we don't accidentally overdose these patients just by looking at the transferrin saturation. Next slide. On to what types of IV iron are currently available on PBS. Like I said, we use Ferinject most often, but it does have a risk of hypophosphatemia. It can only be given up to 1 gram each, but it can be given quite quickly. Now, the product information says it can be given neat over 30 minutes. Due to a relative intolerance, we dilute it and we give it over 30 minutes to everyone except those at high risk of reaction. People at high risk of reaction, we slow it down, and there's a lot of protocols out there supporting that. Ferric Monifer, the other one, is licensed to give up to 1500. It is shown to not cause hypophosphatemia. It takes longer to give, so it does take up chairs for a lot longer. So if we need Monifer, we often have to schedule a little bit more time. In the past, we have used polymaltose. It takes forever to give. You can't give a decent dose, and the reaction rate's something like 2% or more. And I don't think we've ever used Venofer at this clinic. Next slide. So risk and caution for intravenous iron. The reason why I've put active infection on top is because I didn't really find it in a lot of the information that you can find. And when I was a junior doctor in training, a root cause analysis on an ICU death identified the possible iron infusion and in that patient with active pneumonia to possibly causing the deterioration of her situation. And the postulated reason for that is because when a body is fighting an infection, it actually takes most of the iron out of circulation. It deliberately does that to starve the infection. And it's the reason why anemia of chronic disease exists. Chronic inflammation causes a persistent withdrawal of iron from use in the body. And so a person could have enough iron, but they end up iron deficient. So yeah, it is important to check a patient for an infection, check their CRP and take a history, make sure they don't have an active infection because there's a chance that can make it worse. There's also an increased risk of infection in the 2 weeks post an iron infusion. So was first identified in those receiving hip and knee replacements. It has been shown to be a factor in pregnant postpartum women, but most of our obstetricians consider the risk of hemorrhage higher than the risk of infection. So we don't tend to deny pregnant women an iron infusion up to about 36 weeks. Fishbone reactions are the bane of everybody's life who's ever done iron infusions, and I'm sure you might hear more about that. They are non-life-threatening, but they are exceptionally unpleasant for the patient to experience. They are I'll go through them a little bit in the next slide. Other things that everyone needs to be aware of is hives, proper hypersensitivity reactions, which are very, very rare, hypophosphatemia, and polycythemia. So I put the asterisks there because it's not that they can't get iron infusions. It's not that they're going to react. It's just that if you give a person with polycythemia an iron infusion, you're going to make their polycythemia worse. So if you've got a patient and their iron is falling over time, ferritin is falling over time, but their hemoglobin is increasing, probably send them to a haematologist rather than just give them iron. So the hemoglobin is important to assess when thinking about an iron infusion. It's a very, very rare situation that you'll find. You may never see it in your career. As a haematologist, I've seen it more than once. Oh, next slide, please. So we screen for a reaction risk. This is a non-exhaustive list of the things that we ask our patients for before we see them. People who've previously had iron infusions and have had moderate to severe reactions, we don't see in our clinic, and I expect you wouldn't see them at home either because they probably need hospital monitoring or they just don't need iron, they need something else. I had a patient recently, she was sent to me for an opinion. She's reacted to every commercially available iron product on the market, and we just have to give her blood transfusions. People with a history of anaphylaxis to anything, we take extra precautions, mainly with a dose adjustment. We don't necessarily pre-medicate them unless they've had hives or something like that. People with asthma, eczema, that sort of thing are slightly higher risk of reacting, so we slow them down as well. For some reason, and as you can see from the table there, people who come in highly anxious seem to have more reactions. I don't know why, but it is a real thing. Iodine and shellfish allergy definitely increases the risk of hives. And what I didn't put in there recently, I think it might be on the next slide, I believe that dehydration has been associated with an increased risk of hives. Hot weather might be associated with the increased risk of hives. Next slide. The fishbone reaction is also known as complement activation-related pseudo-allergy. So it can come on and look very much like a hypersensitivity reaction, but it's much more short-lived. It is managed by interrupting the infusion, waiting for the symptoms to go away, and then restarting at a half rate. If it doesn't restart, or if the symptoms don't go away in about a 15-minute time, they could actually be having a hypersensitivity reaction. Apparently, so the current thought is that it's due to labile and free iron in the infused solution, so excessive dilution pre-infusion may increase the risk. And we note that it often happens relatively early in the infusion, but we've had them at every stage of the infusion, including right at the end. We don't reject people who've previously had fishbone reactions. We do alter the way we infuse them. We give them a much slower rate. And in the past, we've tried all sorts of things like steroids, and there's no great evidence that it's helped. Next slide. Hives, we do use steroids if people have had a reaction before. Hives, just the true hive reaction is often limited. We have not noticed a lot of systemic symptoms with people with hives. It tends to just be hives. It is surprisingly often that it happens half an hour after they've walked out. They're in the car on their way home and they start getting hives and they have to turn around and come back. So that is something that if a patient is at home receiving the iron and you've packed up and left, could still happen. Most of our patients respond very well to antihistamines, but because it takes a while, we often give prednisolone and antihistamines at the same time. It's very rare that we have to resort to something like adrenaline or Bricanol. And if we use adrenaline, we have to send them to hospital for assessment. If someone's previously had hives, we will ask them to pre-medicate with antihistamines and prednisolone, and in the vast majority of people, that works. And they avoid getting hives in the future. We don't necessarily change from one iron product to another just for hives. Next slide. So I put this in there so that people can look it up if they want to. One of the current pharmacological advice pieces on management of iron reactions. Next slide. Monitoring of iron therapy. So I think it might be because iron infusions are now so much easier and safer to give, but we should still, in people, especially if it's well indicated that they've got a poor diet, try oral iron if they tolerate it. We do get a number of patients who have had a trial of oral iron, only the ferritin's been measured as a increment measure. They haven't checked the hemoglobin. So they miss the fact that the hemoglobin's improved 20 points, but the ferritin hasn't. So they think the iron tablets aren't working. But it's just that iron tablets work really slowly, so you have to check the hemoglobin. If someone's coming into our clinic for an iron infusion, we routinely check for Helicobacter pylori, von Willebrand's disease, because that causes heavy menstrual bleeding, celiac disease, and vitamin D deficiency. Von Willebrand's I will find a handful of times a year, and a lot of people, they might have low von Willebrand's enough to cause heavy menstrual bleeding, but it's often not a problem with surgery. Okay, so borderline and a mildly low von Willebrand's, a lot of people, the only symptom they're ever going to have in their whole life is easy bruising and heavy menstrual losses. They can have surgery, teeth extractions, everything like that, fine. Helicobacter, we will identify most days of the week. We will have patients in this clinic with active Helicobacter infections. So that's the very high rate of detecting that in our patient cohort. Celiac disease, most people with well-controlled celiac disease, the serology should become negative. So if you've got a person with a known celiac, check their celiac serology because it may indicate poor control. We screen them because we will find undiagnosed celiac maybe 10 or more times a year. Vitamin D deficiency is very common and may be associated with the hypophosphatemia and the flu-like post-infusion syndrome. So we check it to be able to give advice on that. Post-infusion, 4 weeks later, so there's variabilities about the post-infusion check. We check for phosphate. We know that it's going to dip and we want to see that it's improved back up to normal by 4 weeks. If it hasn't, we manage that. Very rare liver side effects, so we check that. And we want to check for incremented hemoglobin and iron studies, so we check both of those. Next slide. Intravenous iron-induced hypophosphatemia is now very well recognised. The top left graph, you can see pharynject at the top and monifer is the second one. So monifer does still cause some hypophosphatemia, but not at the level or rate that pharynject does. The top right graph, the top green line is everything other than pharynject, and the bottom two lines are actually pharynject. So hypophosphatemia happens in the first few weeks of almost everyone who receives pharynject. As long as it's transient, it's fine. But if it's persistent, the next time a person comes in for an infusion, we will use monifer on that person. Symptoms of hypophosphatemia probably contribute to the post-infusion syndrome. The post-infusion syndrome is probably, we reckon, 1 in 3 people will feel a little bit unwell after iron infusion. And most people, it's self-limiting and not severe. Treatment, as said in the bottom right, certain types of treatment could possibly make it worse. So oral phosphate on its own probably doesn't work. Oral phosphate with vitamin D does work a bit. We don't necessarily use the oral phosphate. We just recommend vitamin D. Next slide. So this is a slide about how I manage the hypophosphatemia. I check the vitamin D. If they're low, I recommend replacement. A surprising number of our hypophosphatemic patients 4 weeks post-infusion had normal vitamin D. Okay, so just because they have normal vitamin D doesn't mean they're not at risk, but we do get them to hyperdose vitamin D afterwards, and that tends to seem to be quite effective at getting their phosphate back up without likely long-term harm from the vitamin D. Next slide. The other thing I was asked to talk on is the frequency of iron infusions when they need them. I had a man with hereditary hemorrhagic telangiectasia requiring iron infusions every 3 weeks. For a few years, we eventually got him access to a VEGF inhibitor, which is a breast cancer drug, and that allowed him to become infusion independent for about 6 months at a time. I've got another lady, she's got the same disease. She's currently receiving IV iron every 8 weeks. So the iron in and of itself, you can give it as often as a person needs it. As a rule of thumb, if I've got a person who's coming back again, and last time we didn't really identify a source of iron loss, we thought their diet was okay, but they're coming back within 2 years of an infusion, I recommend gastrointestinal investigations if they haven't had them done. If they are menstruating, I take another menstrual history, just in case, say they're in their 40s and they've reached the disordered uterine bleeding of perimenopause. That could now be why they've become iron deficient again. So just because there wasn't menorrhagia or heavy menstrual bleeding 2 years earlier, it could have come on now. If a person in our clinic has shown that they need iron infusions recurrently, so they're coming in for their 3rd iron infusion, I always recommend that the GP preempts their future need. Don't wait for them to get symptoms, because one of the symptoms is inability to seek medical attention. And so they will delay and delay, and they'll come in lower and lower and lower. And it's a morbidity problem. It's a quality of life problem that can be avoided by preempting their need, keeping an eye on them, and infusing them before they get low. And I think that's all. Is there another slide? Yeah, that's all.
Thank you so much, Dr. May, and we'll keep the questions to the end. So if you have any questions, remember, just write them in the chat. Next one, we have Julie to present on providing iron infusions at home after the fantastic talk from Dr. May. Looks good. And we just Lost Julie. Give us one moment, everyone. While we wait, we might answer some of the questions that we have in the chat, Colleen. Let's have a look. Evidence for IV iron is in systolic but no diastolic heart failure, yet we receive requests for diastolic failure HITH. Any comments? Colleen?
Sorry, if the request comes from a specialist cardiologist and the ferritin is not above 300, I will often honour their request to give the iron. I might not give a full gram, I might give a 500 milligram top up. Okay, but if it's coming from a GP and there's no cardiology input, I will often ask for a cardiology assessment in that situation.
Thank you. Next one is, what screening are you using for H. pylori?
Just the serology. So now the serological result is quantitative over here. I don't know. There are some labs who only do qualitative, but when we get quantitative results, if they're sort of borderline, I'll often ask the patient to do a breath test to see if it's active. But if it's a strong positive result, I'll often recommend treatment and then do the breath test afterwards. But yeah, we use the serological one as the screen.
Thank you. Is there any evidence for guidelines on how to approach iron-induced hypophosphatemia, particularly when the home setting, and is the home setting will be fine?
Yeah, so I think anticipating it, so monitoring for it in previous infusions, so not everyone's had a previous infusion, so you don't know. Anticipating it by checking vitamin D, but checking for it afterwards. If a patient calls you up and says, I feel like I got hit by a train 2 days after the iron infusion, they need their phosphate checked because it may be causing their symptoms. If their phosphate's demonstrated to be low and they're severely symptomatic, I know that a lot of people will give oral phosphate and vitamin D. Either preparation of vitamin D seems to work, and then I recheck 2 weeks later. Now, I tend to recommend hyperdosing the vitamin D, so we're talking like 3,000 to 5,000 units a day for 1 or 2 weeks, recheck, and in the vast majority of people, their phosphate corrects after that. The guidelines are really variable, and there's definitely some studies that don't seem to suggest that it works, but at the moment we've had relatively good success. I haven't got a control panel of patients. There aren't patients that I don't give vitamin D to and then recheck their iron. So it could be a placebo effect. It could be that they're going to increase their phosphate within 2 weeks anyway. But that's my current approach.
Thank you. Next one, would you envisage that the HITH involvement with IV iron infusions is mandatorily linked to an iron clinic to monitor usage and adverse effects? So the question, I think it's more, should the home infusions be like part of a at-home, the at-home infusion center should be part of a center at home that patient can come in?
There are a lot of patients, I think similar to chemotherapy, there are a lot of patients, or you could even think about it in a pregnancy point of view. Someone who is low risk is entirely appropriate for a home infusion. So if you have a screening panel, they're not atopic, they haven't previously had a reaction, their screening bloods are okay, so people with significant liver abnormalities might react, so they might not be appropriate for a home infusion. So as long as you've got someone who has no risk factors, they would very, very much be appropriate. But that really is something for the service protocols to sort out. honestly. Like there is, like I said, there's a ceiling that we will even take in this clinic because we're not a hospital clinic. We do have a crash cart, obviously. We can resuscitate people, but we prefer not to. So people who are at super high risk of reacting, we don't take them on.
Thank you. The next one is a theoretical question. Iron is a powerful pro-oxidant. Are you concerned that we don't have long-term safety data on potential added risk of autoimmunity and possibly cancers?
Of what and possibly cancers?
Autoimmunity.
Yeah. We don't have a lot of long-term data on that. No. The post-marketing data is probably quite lacking. So we only have anecdotal evidence from people who've worked in iron infusion clinics for long periods of time. So it's very hard to talk to that because we know very much about the benefit of iron. We know that overdosing a person with iron for a long period of time, you're probably going to induce iatrogenic hemochromatosis. So just like a blood transfusion patient, there is a ceiling to how much you should give. If a person gets an iron infusion and their ferritin is significantly elevated afterwards, it's probably worthwhile checking to make sure it does come back down again. Most people it will. The reason why they were iron deficient in the first place is likely to bring their ferritin back down to a normal range. And so the hyperferritinemia is only for a short period of time. But if a person ends up staying with high iron, that person might need to be managed with venesection to bring it down to a normal level if clinically appropriate. So it is something to be aware of if you've got someone who is symptomatic non-anemic iron deficiency, and say they're small body weight, they're 50 kilos or less, to dose reduce them, especially if their reason is they've got a poor diet, because those people can often get 5 years out of an infusion. So you don't want them having high ferritin for 3 of those 5 years. But the long-term cancer risk, we don't know.
Fantastic. Thank you. Just in time, as I think Julie has managed to join us.
I have. What happened there?
Technology.
And I need to go back, I guess. What did you miss out on?
So unfortunately, we missed all of it.
All of it?
Yes. So we're just answering questions from the chat by Colleen was doing for us. We do apologize.
That's okay. I was brilliant. So let's go back to
Perfect. Thank you.
I'm so sorry. I wish I'd realised. Okay, so I'll follow up. And thank you, Colleen, for filling in there and doing the questions then. I'm going to be talking about the administration of intravenous iron at home, including the risks, reactions and rewards. This is a study that we did at View Health, and I'll talk a little bit about our experience with this. I just wanted to also acknowledge Dan Corrigan and Mankey Lee, my co-investigators on this study. I'll tell you a little bit about View Health, what our aim was in this study, the method that we used, our results and conclusions. So the aim of the study was to evaluate the safety and patient experience of patients referred to a national home infusion service for the administration of intravenous iron. Just to give you a little bit of background about View Health, we have been in business for 12 or more years, a little bit over 12 years now. And we started off having experience with cancer therapies, which is where our name Chemo at Home originally came from. We very quickly developed expertise in immunotherapies at home, considering about 50% now of cancer therapies are immunotherapies, but also to immunotherapies for chronic disease infusions, which includes multiple sclerosis, colitis, rheumatoid arthritis, and including now iron infusions. We have about 1,500 odd prescribers across the country, and this includes all the specialties that we deliver services in: haematology, oncology, gastroenterology, neurology, rheumatology and cardiology. And we do about 20,000 home visits per year across 5 states, and that includes WA, South Australia, Victoria, New South Wales, and Queensland. The method that we used, we have an electronic health record, and so we looked at a retrospective cohort of patients who were referred to View Health Chemo at Home over a 2-year period, from the 1st of January 2022 to the 31st of December 2023. We collected information on their demographics, the concomitant infusions that they received, given that we have a large cohort of chronic disease patients. We do give iron infusions at the same time as other infusions, not at the same time, but one after the other. And we have a net promoter score that we measure in our patients as well. From a safety point of view, we looked at infusion-related reactions, use of our hypersensitivity anaphylaxis standard orders, whether or not we had to transfer any patients to hospital, and our rate of extravasation. So the results were that we gave 1,948 doses of iron to 1,565 patients. As you can see from that, that means that more patients had more than one dose over the 2-year period. We had a median age of 51 years, a range of 13 to 101. And a little like Colleen alluded to in her talk, we have a predominance of females. So we have 75% of our patients who had iron infusions were female, 25% were male. And this reflects not only, I think, the iron infusion data for the primary causes of iron infusion being menstrual loss and pregnancy, but also to the fact that our large cohort of patients with chronic disease infusions, which are of an autoimmune nature, there is a predominance of females affected by colitis, particularly multiple sclerosis and rheumatoid arthritis. So the concomitant therapy, 120 patients or 6.2% had their iron infusion at the same time as another therapy. 70% of those patients had cancer and 30% of them had a medical infusion. The iron preparations that we used were predominantly ferric carboxymaltose in 1,777 patients and ferric deresymaltose in 171 patients. As Colleen also said, there's a difference in the rate of infusion and the dose that can be given. So our doses that we gave were between 250 and 1,500 milligrams. If it's a 1,500 milligram dose and it's the monofer deresymaltose, then we can do that as one dose. But if it's the ferric carboxymaltose or Ferinject, we'll split that dose into 2 separate doses of 1,000 and 500 milligrams. All our treatments that we give at View Health have a fully developed protocol and treatment chart to guide our infusions. The protocols have in them the background to iron deficiency and bloodless management. They also have there the product information, the precautions, any of the administration directions that are needed, including how to make up the product, what to monitor before and after the infusion, and the rate of infusion, etc. Cannulation, we achieved cannulation on the first attempt in 85.1% of patients, so the range of 1 to 5. We don't normally try to cannulate patients more than twice unless we have approval and discussion with the patient over that. So the nurse who's in attendance will call the coordinator, discuss the cannulation of the patient, and with the patient's approval, we may go further than that. Given that some of our patients are well known to us also from their chronic disease infusions, if they don't have a central access device, they will often let us do more than a couple of attempts if necessary. The cannulator described venous access is difficult in 12.4% of patients. And I guess what this actually highlights is that in the home setting, when you're cannulating patients, and you do have patients who are difficult to cannulate, all our nurses are extremely experienced. They've all been trained in the cancer area as well, so they have very good cannulation technique. But even in that situation, you only have one nurse in the home who's cannulating. And so if you run into problems and you don't have, and that person cannot cannulate the patient, you don't have the same level of depth of expertise or resource to draw on as you do in either a clinic or a hospital setting, to try a new person, or send them off to have some other access device put in to be able to cannulate them. We had one patient who experienced extravasation, and they fortunately had no permanent marking. But as we know, extravasation is a serious complication of iron therapy and can cause tissue damage, pain, and potential long-term consequences. We have seen numerous patients and are aware of a number of legal actions that have been taken in various situations, particularly within the hospital setting, where patients have had extravasation and been left with permanent tattooing. We had a young physio who just by chance was being treated, had been given an iron infusion in a GP clinic, but came to us for a different reason. And she had almost a full half sleeve tattoo from her iron infusion, and she hadn't realized it was permanent. No one had told her, and unfortunately she was getting married within the month, and had a sleeveless dress, and was absolutely devastated to find out that this wasn't going to fade and go away. So it is something that we really need to be mindful of, and something that we really need to make sure that we tell patients about and get their consent for treatment so that they're aware of that risk factor. Even in the best of circumstances and the best of cannulations, extravasation can still occur. We also have defined hypersensitivity anaphylaxis procedures and standing orders. This goes for all our treatments that we give. And so they are consistent across the board of whether it be iron infusions, chronic disease infusions, or our cancer therapies. And this breaks up hypersensitive and anaphylaxis according to mild and moderate or severe and anaphylaxis. These guidelines are based on the Australian Immunology Society and the Australian Resus Council's guidelines. So looking at the toxicity of the treatments now, we had 17 patients, or 0.87% of our patients have infusion-related reactions. This included chest tightness, shortness of breath, dizziness, nausea, hives, itching, redness, sneezing, watery eyes, hypotension, and vasovagal reactions. And I think the infusion-related reactions emphasise that while iron infusions are generally safe, they can cause adverse reactions, and some of these can be severe. And it's really important for nurses when they're in the home to understand the reactions, understand what the severity of them is, understand whether or not they're likely to be self-limiting, and respond to just stopping the infusion for a few minutes and then restarting at a 50% rate, or whether they're likely to progress on to something more severe. We used our HAZO medications and our HAZO protocol in 10 patients. And I guess this also highlights the importance of having the protocols in place. As we all know, if patients have a reaction, particularly when you're in the home and there's only one nurse there who's there to manage the reaction, they need to be very confident in what they're going to do. You don't want them to be panicking at that stage and not know what the protocol is and what the algorithm is for treatment. And I think for us, this is one of the areas where we are really lucky. We have the same protocol across all our treatment regimens for how we manage infusional-related reactions and anaphylaxis, and it means our staff are extremely well trained and experienced. They come across these reactions not only with iron infusions, but with immunotherapy, chronic disease infusions, and with cancer therapies like the taxanes and the platinum drugs as well. So we don't uncommonly have infusion-related reactions, and our nurses are very adept at using our protocol for this. The medications we used in these situations included hydrocortisone, antihistamines, bronchodilator, and a saline bolus. The good news is that 16 of the 17 patients were able to restart the infusions and complete their infusions at home. And as Colleen pointed out, I think one of the really important things to note, though, is that patients do have reactions in the post-infusion observation period. It's really tempting when you're a home nurse, when you've finished the treatment and you've packed up all your gear to leave. But it's really, really important for that half-hour monitoring period to stick around and monitor the patients, because 4 of our reactions were in that post-infusion observation period. In fact, one of the reactions was the nurse had got into the car and was leaving. She was still in the driveway, but she was still there. And the patient rang her and said she was having a reaction, and she popped back in to support her care at that point. But that post-infusion period, I think, is really critical. And unlike many of our other reactions, which often for immunotherapy and the platins and taxanes happen during the infusion, and rarely happen after the infusion, iron is a little bit of an outlier in this sort of respect. So it is really important to remember that. We had to transfer one patient to hospital, and the reaction they had was loss of consciousness. Their breathing stopped. Their pulse was not detected. We, according to our own protocol, attached the defibrillation pads. She was not shocked. She was given a sternal rub and she regained consciousness, thankfully. The net provider score we measure in all our patients. And for those who aren't familiar with a net provider score, it's a score that actually goes between -100 and +100. And it sort of breaks results up into people who promote your service, people who detract from your service, and those who are passive that sort of sit in the middle. So we have a net provider score for these infusions of 93, which is very high. Just to give you a bit of a sort of a ballpark figure for other things, health insurers often have a negative score. I think some of the ones in Australia have scores in around the 30 or 40 positive. And Ramsay as a group has a net provider score of 72. So a 93 is really good, and we're really proud of the fact that we are able to offer people a good experience by having their iron infusions at home. So in conclusion, I just wanted to highlight that this is the largest reported cohort of patients treated with an iron infusion in the home setting, and that whilst iron infusions are generally safe, infusional-related reactions do occur. Staff need to be trained on how to manage these reactions and be confident and competent to do so, considering they're the only person in the home at the time that this occurs, and that hypersensitive anaphylaxis protocols need to be in place and the medications available for if this occurs at the time it happens. You need to be very cognizant that extravasation leading to permanent tattooing has been well documented. It's led to a number of legal cases in Australia, and it is something that we need to make sure that the patients are educated about on the risks, and we need to explain it to them, and that cannulators need to be both confident and competent as well. But even in that situation, it can still occur. And to highlight that the NPS for home-based infusions is very high. Basically, patients very much appreciate the convenience, the improved access to care, and the comfort of home-based treatments, particularly in this situation where so many of the patients are female, and often after having had a second or a third pregnancy might be when they're getting their iron infusion. They already have children to look after, or a job, or a house to look after, and they very much appreciate being able to have their treatment at home rather than having to go to a clinic or a hospital and have to find childcare arrangements for their other children or to take additional time off work. We also treat patients at their workplace if they choose to have that done there as well.
Fantastic. Thank you so much, Julie.
That's okay. I just like to acknowledge all the specialists that send their patients to us, and of course the families and the patients who welcome us into their home, and our team who are extraordinary. Thank you.
Thank you for the great presentation, both from yourself, Julie, as well as Dr. Colleen May. We do have some questions. It is the end of the hour, so people can leave if they wish, but we'll just end with a couple of questions if that's all right. So one is, do you have a protocol for managing iron staining when administering iron at home?
No, we don't have a protocol for how we manage the iron staining, because I don't think there's any way to actually reduce it. What we do have is a way of managing our extravasations. So we have an extravasation protocol, and that includes obviously withdrawing as much as we can from the site, stopping the infusion, withdrawing as much as we can from the site, and then removing the needle and the cannulation. But as far as what you can do to actually prevent the iron staining from either progressing, I'm not sure. Colleen may have more information on this than me, but I'm not aware of anything that actually either prevents it from developing or makes it go away, over time.
So one of the things we've seen, because we've also given second opinions from about stains that have happened in other services, as well as having, luckily very few, but still unfortunately some iron infusions that do stain, is that the stains can get worse over time. Sometimes they can take a few weeks or months to actually become their worst. We do send patients with significant staining who want it to the laser tattoo removal services, and they have had some success.
Fantastic, thank you. The next question is, what is the funding stream or / who covers the cost for an in-home infusion for iron?
So for us, we have health fund contracts with all the private health insurers, and they cover the cost of the infusion.
Thank you. The next one, do you do iron infusions?
And I will say, sorry, we do actually have a group who don't have private health insurance who do pay privately themselves as well. So that can happen too.
Thank you. And are there exclusion criteria for home infusions?
Yes, there are exclusion criteria for home infusions. More broadly, it's about where the patient lives, what support they have at home. When it comes to iron infusions, it's very much what Colleen has referred to in her presentation around the safety. So if they've had previous iron infusion reactions, anaphylaxis, that would preclude them from having treatment at home.
Perfect, thank you. And the next question, that's going to be from me to both yourself, Julie, and Colleen. Is there a need for a doctor in the room when there's an infusion? So a lot of HITH services do send out a doctor and a nurse. Do you think that is necessary?
I'll let Colleen answer that first.
The way we approach it is that it's an indemnity thing, not just best practice, but there's also an indemnity thing. While the nurses do the hard work, they are not ultimately responsible for the patient. It is the doctor. The buck stops at the doctor, and the doctor probably does still need to be there. Even if the doctor's only doing anything once every 200 patients, it is still their responsibility.
As far as we go from a home point of view, obviously the doctor's not in the home with the patient. And for us, although iron infusions do have an infusion reaction, we have treatments we give that have much higher rates of reaction, and that we give them at home safely. In fact, we've shown in our data across the board that because in the home setting, a nurse is sitting with a patient one-on-one, they are far more likely to recognise a reaction early when a patient just starts inadvertently scratching or just trying to clear their throat or something like that. And our reactions are in the mild to moderate category rather than severe, which is much more common in the hospital setting when nurses aren't sitting with the patient one-on-one. So from our perspective, we consider our hypersensitivity anaphylaxis orders to be state-of-the-art, plus also to the fact that you've got one-on-one care in a patient's home means that the level of attention to the patient is greater than either in a clinic or a hospital situation at the time that a reaction could occur. So, we have obviously indemnity for ourselves as well for our service. But as I said, we've given not only iron infusions, but, tens of thousands of other infusions in cancer patients and chronic disease infusion patients, and have got a very good track record for how we manage infusion-related reactions.
Yes,
Perfect.
so that just reflects the different services that we run. So it is absolutely unfeasible to have a doctor at each home infusion, whereas in our clinic we have I think a ratio of 1:4 or 1:2 on a good day, nurses to patients. So we always want a doctor in the clinic at the time the infusions are going. So it's just the realities of the different types of service.
Amazing. Thank you. And the final question before we send everyone off is, IM polymyaltosis offered by some GPs where IV is a problem. Thoughts about that?
It hurts, it stains badly, it takes a really long time to work. And I think that it's technically been superseded by intravenous iron. So I don't think it's effective enough in most people to be worthwhile. Acknowledging that I see a very selected group of patients, like I see the ones where the oral iron doesn't work. Okay. I see the ones where they're needing it really often. I see the ones who don't have GP access. I see the ones who don't want the intramuscular iron. Okay. So I acknowledge there's probably a large cohort of patients out there who probably do well with IM. I just don't see them.
Perfect. Excellent. Thank you so much, Colleen. Thanks so much, Julie. Thank you, everyone, for attending. Julie, there are lots of questions specifically for you in the comments. See if you want to have a look. But really, thank you and have a beautiful rest of your day, everyone.
Thank you very much.
Thank you.
Thank you.
Bye.